Welcome to the December 2023 episode of Diabetes Care on Air, a fun way to bring the research in diabetes care to life. Today, we are featuring the content of the year's final issue. My name is Mike Rickles from the University of Pennsylvania.
And I'm Alice Chang from the University of Toronto.
As per usual, Alice and I will be interviewing authors of feature articles as selected by the editors of Diabetes Care, followed by our rapid exchange segment where we give brief summaries of articles we found of particular interest.
It's December, Mike. Lots of things to look forward to this month, including time off, hopefully, for the holidays. I know that I'm particularly looking forward to more sleep, less work, and more time with family and friends. How about you, Mike?
Absolutely, Alice. And I think it's especially important to have this time each year to take pause, give thanks, give back, and show appreciation of those close to us. And like prioritizing sleep and exercise, which we talk about a lot in this podcast, prioritizing our relationships with each other is a tremendously important part of health and well-being. So here's to the holidays and to good health in the new year. And let's get started with our author interviews.
One of the feature articles from the December 2023 issue of Diabetes Care is titled Diabetes and Multiple Long-Term Conditions, a review of our current global health challenge. We have with us today Professor Kamlesh Khunti from the Diabetes Research Center at the University of Leicester in the United Kingdom to discuss this paper in greater detail. So thank you, Kamlesh, for being part of this podcast.
Thank you very much, Alice. A real honor to be here again.
So this is the second time that I've had the pleasure of interviewing you for this podcast series. So welcome back and congratulations for having yet another feature article in Diabetes Care. So you and your colleagues have produced this paper, which I think is a very important one for all of us to consider. But let me start off with the very first question that popped into my head just reading the title. What exactly does the term multiple long-term conditions mean? And is that the same as multimorbidity? And what was wrong with multimorbidity?
Okay, great question. Multiple long-term conditions is exactly what we used to call multimorbidity. It's people living with two or more chronic conditions. And the reason we've started calling it multiple long-term conditions is because interviews being done with patients has revealed that they do not like the terminology multimorbidity. They say we are not morbid.
Right. Yes.
We have multiple long-term conditions. I think that a lot of it is about language and the language that we should be using, which is acceptable to people with these long-term conditions.
That's a great point, right? We use the term morbidity, but we don't really think about how it sounds from a lay perspective. That's a great point. So why was this an important topic to review? And what do you mean by diabetes-related multiple long-term conditions?
Well, I got into the area of multiple long-term conditions or multimorbidity research about 10 years ago. Our chief medical officer was very much in the opinion that this is something that we're going to see more of over the years. And I'm glad I got into this research so early on. And the main reason is that because we're living longer. Mm-hmm. We're living longer, but we are accumulating more and more conditions. So people overall will live longer, but with multiple long-term conditions. And particularly diabetes, because diabetes is one of the commonest chronic conditions. And when you look at clustering, etc., diabetes is often the epicenter of multiple long-term conditions. More people with diabetes will have multiple long-term conditions than others. So just to give an example, if a person has diabetes at population level, only 17% will have diabetes and no other conditions. 82, 83% will have diabetes in another condition. If someone's aged less than 65 and they have diabetes, they will have two other conditions with diabetes. If they're over 65, they will have diabetes and another 5.5 other conditions. So it's going to be a norm for people to live with multiple long-term conditions.
It seems like this rising global, because it's a global issue, isn't it? So this global prevalence of diabetes and multiple long-term conditions is ironically a byproduct of our success in managing chronic diseases and leading, therefore, to longer lives. Now, let's talk more about some specific conditions, because within your paper, you go through some specific conditions and their relationship with diabetes and MLTC. So let's start off with obesity.
Well, obesity is a huge driver for multiple long-term conditions. The exact mechanisms aren't known, but it could be due to inflammatory pathways. It could be due to insulin resistance, but we don't really know what the exact reasons are for developing multiple long-term conditions in people with obesity. But we do know that the more obesity you have, the higher the prevalence and incidence of multiple long-term conditions. And there's been quite a lot of data showing that with obesity, they've a study looking at 21 different conditions that they were more prevalent as you increase your BMI. We've also recently shown that if you lose weight or increase weight, looking at 13 conditions, about 8 or 9 of them were associated with either a reduction in risk incidence or increase in incidence, depending on weight trajectory. So for some conditions, you only need a 5% weight loss or weight gain to lose or get that condition, while for others, you need to have 20% of weight gain or weight loss. So certainly, obesity is in the pathway. Whether it's in the causal pathway or not, we're not sure.
Mm-hmm. And it seems like as our population is A, getting older, and then B, also obesity prevalence is rising. I mean, given the strong relationship that MLTC is already and will continue to become a bigger and bigger issue. Now, the other section that you had was about communicable diseases, which I got to say would not have naturally been something I would have thought of in terms of MLTC. So can you elaborate on that?
Yes, it's not well known, but communicable diseases, particularly certain infections, and we've certainly recently seen COVID affect us more. We know that people with diabetes were more likely to get infected with COVID and worse outcomes. But our work and other people's work has shown that once you're admitted, you're more likely to have other conditions develop as well, new conditions develop while in hospital. These are often cardiometabolic conditions. There isn't any data at the moment regarding long COVID, whether long COVID is a chronic long-term conditions. We haven't defined that as yet, but there is new emerging data coming on long COVID and diabetes once people have been admitted as well. But in terms of other infectious diseases, the two particular ones are HIV and tuberculosis. And HIV and tuberculosis, again, we're not sure whether it's through similar pathways of obesity, so this is inflammatory pathways or insulin resistance pathways, but it could also be because of some of the therapies that people with HIV have, and they may cause mitochondrial dysfunction, making people have other long-term chronic conditions. But certainly there's some really good work that's come from Africa and India looking at the coexistence of the infectious disease and diabetes.
Mm-hmm. And there are some special populations that you and your group mentioned as well, including early onset type 2 diabetes, as well as type 1 diabetes, of course. So can you expand further about how these relate to MLTC?
So early onset diabetes, I know it's of great interest globally at the moment. We know that the incidence of early onset diabetes is increasing. And the main drivers, we think, for multiple long-term conditions in this population is, first of all, there is a greater lifetime risk. It's also, they are more likely to be obese as well. And the chronic hypoglycemia may be causing some of the increased risk of multiple long-term conditions in this population. And some of the best data really have come from studies like the Today study, where we know there were people with type 2 diabetes below the age of 20. And even at baseline, they already had diabetes in some conditions, such as about 20% having hypertension, dyslipidemia, 9% having microvascular complications. But over a 10-year follow-up, there was a huge increase in proportion of people getting other conditions. So about 47% getting hypertension, 44% dyslipidemia, and 80% microvascular complications, showing this is a more aggressive disease. US data has also shown very little data from the UK yet, but it is emerging that, again, ethnic minorities may be more affected. We know type 2 diabetes is more prevalent in ethnic minority communities. We also know multiple long-term conditions are more prevalent in ethnic minority communities. So both of these together may put ethnic minorities at a higher risk of accumulating multiple long-term conditions.
And then type 1 diabetes, what is the relationship there?
Yeah, type 1, there isn't as much work that's been done in type 1 diabetes as it has for type 2 diabetes. But again, there may be three mechanisms here. First of all, again, lifetime risk, because they get the condition much earlier. Secondly, it is autoimmune related. So you're more likely to get other autoimmune diseases, and we know that occurs in people with type 1 diabetes. And the third pathway could be, again, obesity related. We know people with type 1 diabetes are getting more obese. So that may be another reason for them getting increased lifetime risk of multiple long-term conditions.
So the presence of MLTC poses many challenges, obviously, for the individual as well as service delivery and things like reduced quality of life, worse health outcomes, higher mortality, strains on the healthcare system. So what are some of the current interventions for prevention and management of this issue?
I think that's where the research really now needs to focus, because we have a huge amount of epidemiological studies, and epidemiological studies vary. And if you look at the prevalence of multiple long-term conditions, they could vary from 30% to 100%, depending on what population you're looking at. But on average, we think it's around 20 to 30% in people with diabetes. So that's where most of the work's been concentrated on so far. Intervention studies, there's very few. There's a randomized controlled trial of a model of care that was done in UK, 3D model of care, which didn't show improved outcomes. Primary outcome was quality of life. It did show that quality of care improved in people. There's been 2 specific RCTs that we're aware of in people with diabetes, but they didn't see any change in physical or mental function in this population. We know from lifestyle changes, look ahead, Ching, that you could improve physical fitness, you could reduce the risk of cardiovascular events, you could reduce the risk of microvascular complications if you intervene. But these are really intensive interventions to reduce that risk, which are not, we know from look ahead, they're not sustainable for the longer term. But I think therapeutic interventions are a great breakthrough we've seen recently. I mean, particularly if we look at the recent therapies, well, they're not so recent, such as SGLT2 inhibitors and GLP-1 receptor agonists. We know that they have reduced the incidence of certain conditions, which we would call multiple long-term conditions of people with diabetes. So, for example, future CVOTs, heart failure, kidney disease, all of those are reduced. So certainly the therapeutic options are there to reduce the development of multiple long-term conditions. Other area we don't put much emphasis on, de-intensification. That's a therapeutic option that we really should be reducing the therapy burden of people with long-term conditions, multiple long-term conditions, because they do have polypharmacy, and we could reduce the risk of them developing adverse events due to the therapies that they're on, the multiple therapies that they're on.
So it sounds like there are system interventions that still need to be worked out from what you're saying. And then I keep thinking as I'm listening to you, I mean, aging, we cannot change. In fact, that's kind of why we do what we do, is we hope people will live longer and get older. But the upstream intervention around overweight and obesity may be a very important potential intervention to avoid. It's almost like collecting different conditions over time. And I mean, frankly, in childhood is probably the best time to be intervening, in adolescence and those healthy habits, et cetera.
Absolutely. I think lifestyle is where we need to go rather than thinking about therapeutic options. And if we start early, as you say, we know people who are more physically active are less likely to get multiple long-term conditions. We know that, and we've just talked about obesity as well. So diet and lifestyle should be the key. And as you say, really from birth and school-age children, to reduce this huge possible tsunami we're going to have of multiple long-term conditions going into the future.
Now, let's talk future research. I mean, you've got an audience here of current and future researchers. So, Kamlesh, I want you to inspire them. So, what are some of the key research directions from a global perspective that are needed on this topic?
Well, I think we've seen some of the areas we talked about. There is lack of research in type 1 diabetes in terms of the epidemiology of multiple long-term conditions. Type 2 has been done quite extensively. Young people with type 2 diabetes, young onset type 2 diabetes, and the epidemiology, I think, again, needs a lot more work. But we really need to go into the interventional studies, looking to see how can we, first of all, prevent a multiple long-term condition coming on. And secondly, if they do have multiple long-term conditions, how can we prevent additional ones coming on, improving quality of life and reducing mortality risk as well. And this could be different levels. So one is system level interventions. At the moment, a person with diabetes, type 2 diabetes particularly, could be going to 5 different clinics, hypertension clinic, diabetes clinic, cardiac clinic, CKD clinic, depression clinic, and having a multiple long-term conditions clinic as a randomized controlled trial. And that's what 3D tried to do, but they were doing it more generically of everyone with multiple long-term conditions. I think we could have a great opportunity to do this for people with cardiometabolic conditions, because we know they're very confined. We know some of the risk factors are similar. So doing that and seeing patients could have a major benefit. And that is a study I think that certainly needs doing. Therapeutic options, there are new therapeutic options, and we're very excited at the moment about obesity. And again, I've been speaking to the trialists, speaking to the companies to say, you mainly look at CVOTs. What you need to think about is other multiple long-term conditions and get them into secondary outcome measures, such as depression, such as back pain, osteoarthritis. All of those are important chronic conditions that people with type 2 diabetes will accumulate. Type 1 diabetes and interventions, I think, again, a great area that we need to work on as well.
Funny, as you're talking about a clinic that deals with all of the issues, I just thought that's primary care. I mean, I think we're coming back to recognizing the importance of primary care. Now, it's not realistic to expect one individual to be able to do all of that work, but I think primary care has always looked at the whole patient and all of the multiple long-term conditions of that individual. So I think there's the plug for good primary care.
Absolutely. And we're doing that already. So we set up a multiple long-term conditions clinic in our surgery probably about 10 years ago. So people used to come to 5 clinics. Instead, what we do is give them a longer appointment with a nurse. And if they've got 3 or more conditions and they get consistent advice, they're less likely not to turn up, what we call did not attend. And I think that they're probably more satisfied. We haven't done an evaluation. I think what we need is a trial to do that and look at outcomes in these populations.
So you mentioned different trials and studies that could be done, but what outcome is actually of interest to people living with multiple long-term conditions?
There's been quite a lot of work that's been done interviewing people with long-term conditions and particularly multiple long-term conditions. And the outcomes they're interested in is obviously they want to live longer, but they want to live longer and in a healthy and happy life. So it's quality of life that really matters to them as well.
Excellent. So thank you, Professor Kamlesh Khunti, for your expertise and discussing this important and ever-growing global issue. It sounds like lots of work to be done to better understand how to prevent and manage. And as I said earlier, and as you said, as our population is getting older, this is going to become more and more of an issue that we certainly need to address. So thank you again for sharing your knowledge. And I encourage the listeners to read the full article in the December issue of Diabetes Care.
In the December 2023 issue of Diabetes Care is a feature article entitled Dasiglucagon Treatment of Postprandial Hypoglycemia After Gastric Bypass, a randomized, double-blind, placebo-controlled trial. I'm delighted to introduce the article's lead author, Dr. Casper Nielsen. Dr. Nielsen is a postdoctoral researcher at the Center for Clinical Metabolic Research at Copenhagen University Hospital in Denmark. Welcome, Casper. Congratulations to you and your co-authors on this feature article.
Thank you so much.
Postprandial hypoglycemia is a challenging disorder that can develop in individuals who've undergone Roux-en-Y reconstruction of the upper gastrointestinal tract and often presents as a late complication of gastric bypass surgery for obesity. Can you tell us a little more about how this form of elementary hypoglycemia is currently being managed and how you came to this low-dose glucagon approach tested in your study?
Yes, and thank you. Currently, there is no official clinical guidelines for the treatment of this complication. But in general, you can sort of divide the treatment categories into 4 separate categories. Those are dietary advice, meaning adherence to very strict low carbohydrate intake, especially avoidance of monosaccharides. And that has some efficiency in preventing hypoglycemia, but obviously has poor sustainability and persistency for the long run. And the 3 other categories are based on the drug treatment. First, you can call it an insulin inhibition treatment modality. So aiming to reduce the hyperinsulinemic state that ensues postprandially in these persons who have a gastric bypass procedure conducted. So those drugs are somatostatin analog and GLP-1 receptor antagonists. They have their own pros and cons with them, which I won't go into detail with in spirit of time. The third category is in favor of lowering the glucose absorption rate, either intestinally or secreting glucose with the urine. So meaning SGLT2 inhibitors is currently tried in various research groups, but the most often used off-label drug is acarbose in this category, which is an alpha-glucosidase inhibitor, lowering the glucose absorption for the intestines and just resulting in a lower postprandial glucose peak, which lowers the insulin secretion. And the fourth category is counter-regulatory, and that is where glucagon comes into play. And within the recent years, an enormous step has been made into developing glucagon as a non-reconstituting molecule. So it means that it is a stable molecule in a liquid formulation now, which enables ready-to-use action. So our theory was a low dose of dasiglucagon would counter hypoglycemia back to normal glycemia, and we were very much eager not to cause iatrogenic hypoglycemia. That was the goal with this study.
So, Casper, in your study, 24 individuals used either a 120 microgram dose of dasiglucagon or placebo by an injector pen at the time that postprandial hypoglycemia began. And you define that as a sensor glucose by continuous glucose monitoring of less than 70 milligrams per deciliter or 3.9 millimoles per liter. And this was done during 2 4-week randomized double-blind crossover periods with either the 120 micrograms dasiglucagon or the placebo. Now, on average, treatment with either intervention was used almost daily by the study participants. So they clearly were seeing a lot of postprandial hypoglycemia. And use of dasiglucagon significantly reduced the CGM time spent with level 1 hypoglycemia, defined as being less than 70 milligrams per deciliter, and also reduced time with clinically important level 2 hypoglycemia that's defined as being less than 54 milligrams per deciliter or 3 millimoles per liter. So in addition to demonstrating this efficacy on reducing time with both level 1, level 2 hypoglycemia, can you tell us anything more about the impact of the dasiglucagon intervention on glycemia in this cohort?
Yeah, in terms of hyperglycemia, it was reassuring to see that the dasiglucagon treatment arm did not induce iatrogenic hyperglycemia above 7.8 and 10.0 millimoles per liter. I'm not sure what that is in milligram per deciliter, but the levels of hyperglycemia at least was not increased. In fact, we did see a small increase in range. No, it was not statistically significant when adjusting for multiple comparisons. So that was an important finding that supported the effect of this drug. But most of all, the finger prick measurement, the self-monitoring blood glucose levels conducted just prior dosing and 15 minutes later were pretty evident that the participants' blood glucose levels rose by 2 millimolar 15 minutes later, which ultimately ended up by significantly reducing the need for glycemic rescue therapy due to marked neuroglycopenia or a critically low glucose level, and also a pretty high correction rate of 97% when dosing the dasiglucagon. So a correction of hypoglycemia within 15 minutes in 97% of the time. So those were pretty important glycemic findings in this study.
Yeah, so it seems like the action of the dasiglucagon is super fast, and that really seemed to contribute to the reduction of hypoglycemia, but also, as you point out, less need for additional intervention and rescue. And knowing how hard it is when individuals are hypoglycemic to resist on over treating with carbohydrate ingestion, to see an intervention react so quickly in terms of restoring glucose is quite impressive. And so there have been previous studies examining the use of glucagon for prevention or treatment of post-gastric bypass hypoglycemia, with some, albeit more limited, success. Can you speak to some of the differences in the approach studied here that you think might explain the greater success you report with the low-dose dasiglucagon intervention?
Yeah, so as far as I'm aware, there are currently 3 other glucagon therapeutic intervention trials out there published. One was a case report and 2 were in-clinic experimental with a automated glucagon delivery system, a rather sophisticated glucagon system, which I think they had some timing issue. It was spearheaded by Elizabeth Patty's research group. So they might have some efficiency if they tested it out in an outpatient part as we did, which makes it pretty hard for me to compare our study to those 3 studies since our study was largely done in an outpatient setting. If I should point out some of the factors that might explain some of the success that we had with this study is I think we used the right dose, the 120 micrograms, in terms of a most beneficial risk-benefit ratio. I think we had a rather well worked through dosing diagram as when to dose for the participant. It was quite comprehensive and cumbersome at first, but after learning it after a couple of days, they were adjusted to it and they could, with some confidence, know when to dose. And we also had a pretty close interaction with the participants multiple times daily within the first week, which I think just massively improved the findings of an outpatient study with self-administration of a drug. You really need them to be in a close encounter to make sure that they actually follow the protocol.
A terrific proof of concept that this intervention can really be successful. And as you point out, implementing this may take several forms. And clearly you showed one that certainly works and makes this an important strategy for future research. And getting to the dose. So now dasiglucagon was associated with nausea in about a third of the participants. And nausea is a known effect of glucagon due to relaxation of gastrointestinal smooth muscle. And a recent study in the July issue of Diabetologia used an 80 microgram dose of dasiglucagon in individuals with type 1 diabetes on insulin pump therapy, showing there in an outpatient setting, it could reduce time spent with hypoglycemia. And so you said you were happy with the 120 microgram dose selected for postprandial hypoglycemia affecting individuals with gastric bypass. So I wanted to ask if you thought that there'd be any reason to think about a lower dose like 80 micrograms, or whether you might tailor the dose based on tolerability and efficacy, and what your thoughts are on what the dose range might be for the population who could potentially benefit.
Yeah, so it's a great point. And the short answer is yes, I think 80 micrograms could provide beneficial effect in mitigating hypoglycemia as well for some individuals. We actually tested 80 micrograms of dasiglucagon along with 200 micrograms of dasiglucagon versus placebo and published those results also in Diabetes Care last year, albeit it was a preventional measurement before the onset of hypoglycemia. And we were not convinced that 80 micrograms would be enough to sufficiently combat the state of hyperinsulinemia. So the state of hyperinsulinemia is pretty extreme in this group of patients. It's around 5,000 picomolar, peaking around that level, also with some areas, of course. So we did not statistically see a prevention in level 2 hypoglycemia when testing 80 micrograms in the last study, not this study, which ultimately made us to choose just a tad lower dose for the entire group here. Now, in terms of the nausea, the bouts of nausea, that is the most common side effect of glucagon therapy, dose dependent. So the higher the dose, the more the risk to develop nausea and also subsequently vomiting. There were 3 persons in this trial who accounted for 20 out of the 25 bouts of nausea. So those 3 persons probably would benefit of a lower dose of dasiglucagon, which could be done because it was a multi-dose reusable pen, so you adjusted the dose pretty easily. But there were no treatment emergent adverse events that led to discontinuation of the treatment in the trial. So it was fairly good tolerated, at least, I think.
Terrific. And now, Casper, 23 of your 24 participants in this study were women. And your article points out that more women than men undergo gastric bypass surgery. But it still seems to me that women may be disproportionately affected by the development of post-gastric bypass hypoglycemia. Can you elaborate or speculate more on this sex imbalance in the participants that were eligible and contributed to your study?
Yeah, it's a great point, and I do consider this as a limitation of the study that we had 94% female participants. The bariatric population is around 80% female, so it's not that far off, but still far off. So in terms of being a risk factor, being female in developing post-bariatric hypoglycemia, I'm not that convinced of the data as of right now. It's still not that clear. There is some factor, and the female gender has been suggested along with a younger age, a lower HbA1c before surgery, also the lack of type 2 diabetes before surgery, and also a high weight loss post-operatively. And I think it's important to notice that men, when they receive a gastric bypass operation, they tend to be more sick than females with more obesity-related comorbidities, such as type 2 diabetes. So I would speculate that maybe since the men are probably more sick with a high degree of insulin resistance before surgery, it could make them less prone to develop these complications after. So that's for me to speculate.
That's terrific. Wonderful explanation. And now I'm curious what next steps you have planned for additional testing of this low-dose dasiglucagon approach for prevention and treatment of post-gastric bypass hypoglycemia.
So also a very interesting question. The ball is definitely in the courts of Zealand Pharma, who is the manufacturer and the provider of dasiglucagon. I'm not sure if they have a clinical phase 3 program with a multiple dose reusable pen with dasiglucagon. I think they definitely should have. I think there's a clinical potential in this having huge treatment effects for this indication. For me, I would like to see dasiglucagon head-to-head against the Archibos. That is, the first in line off-label drug for this indication. And I think with this setup, dasiglucagon will probably outperform the effects seen with Archibos. These effects from this study was not on top of dietary advice, which you typically see in the literature, a drug, somatostatin analog or Archibos, on top of dietary restriction of carbohydrates, which further emphasizes the findings of the studies, I think.
Great. And Casper, any final takeaway messages for our listeners?
It might be that the gastric bypass may come about having a bad rep out there because of its complication. But I would just like to remind everybody that it's an enormous efficient treatment for severe obesity, correcting type 2 diabetes, improving quality of life and sustainable weight loss, and also prolonging the lifetime expectancy. So that's pretty important to point out. And also I would like to encourage all researchers out there to conduct these clinical trials, which is just a bit longer than the experimental in-clinic studies with mixed meal test or HSTs, because we need those to get a hold of how to best treat this indication. And lastly, of course, I would like to thank you for giving me the platform to convey these results, and to all the collaborators and stakeholders and co-workers, and definitely all the participants who really I had the deepest admire for and worked pretty hard to get these results as good as they are.
Beautiful study. Dr. Casper Nielsen, I really appreciate your joining us and discussing these very encouraging results using low-dose dasiglucagon for post-gastric bypass hypoglycemia. I really believe these findings will have relevance for other forms of alimentary hypoglycemia as well, and I hope will one day soon be available clinically for our patients struggling with this challenging long-term complication of upper gastrointestinal tract surgery. Thank you, Casper, and our listeners, who I encourage to read the full article in the December issue of Diabetes Care. Let's move on now to our rapid exchange segment, where Alice and I chat about some of the articles we found particularly interesting this month.
Sure thing, Mike. You want to start us off?
All right, Alice. I'll start with an article by Dr. Xian Xiao from the University of Texas Health Sciences Center in Houston and colleagues who analyzed alignment of the 24-hour light-dark cycle with the 24-hour activity-rest cycle in 7,000 adults from the National Health and Nutrition Examination Survey using multi-day actigraphy data. What they found was that those individuals with lower alignment of light with activity and dark with rest had an almost twofold greater risk of diabetes and impaired glucose metabolism, an effect that was primarily driven by delayed activity rest cycle relative to the light-dark cycle. And importantly, this relationship was consistent across diverse sociodemographic groups. So these real-world data really emphasize the importance of circadian biology to much more than what's been established for shift work and jet lag, and really offers another target for improving outcomes for metabolic disorders. Going to bed early.
And Mike, I'm listening to you, and this reminds me of that old saying, early to bed, early to rise makes a man healthy, wealthy, and wise. And this somewhat resonates with that. But the struggle I have living here in Canada is that it's dark now at 5 p.m. So if I were to listen to this, I'd have to go to bed super early, which means that we'll not have time to record this podcast.
Yeah, we're doing that in the dark right now, Alice. So it's we're already losing this game.
That's a good point. That's a good point. So my first pick for the Rapid Exchange from this month's issue is from Dr. Xiantong Zhou and colleagues with the senior author of Professor Linong Ji from the Peking University Diabetes Center in Beijing, China. They identified a rare variant of the metallothionein 1E, or MT1E for short, gene, in a 3-generation family with diabetes called C36Y. So C36Y, the letter Y. They then assessed for this risk allele in a large community-based cohort and confirmed that carriers of the C36Y did in fact have higher A1C and higher BMI. To further test the hypothesis, they performed in vivo validation by forcing overexpression of the MT1E C36Y variant in mice, and those mice had more weight gain, hyperglycemia, and hepatic steatosis. Whereas those mice who had forced overexpression of a different variant, C36C instead of Y, had lower weight, glucose, and triglycerides. The authors suggest that looking into rare variants like this can provide insight into potential treatment targets for type 2 diabetes, which I thought was very interesting. And I can just see it now, Mike. It'd be a new treatment class of MT1E C36C inducers, just to add to the alphabet soup that we already have in diabetes treatment now.
Yeah, Alice, this is another great example of human genetics providing novel insight into disease pathogenesis. And I too really hope that this mechanism is soon targeted for new diabetes intervention. Next, I have an article from Dr. Oana Patricia Zaharia from the Heinrich Heine University Hospital in Dusseldorf, Germany, and colleagues who examined physiologic measures of insulin clearance in 306 individuals with recent onset type 1 diabetes, 489 individuals with recent onset type 2 diabetes, and 167 normal glucose tolerant control subjects. And insulin clearance measures were already reduced in individuals with recently diagnosed type 1 and type 2 diabetes, and appeared further impacted by glycemic control in those who had type 1 diabetes and by hepatic steatosis in those who had type 2 diabetes, where lower insulin clearance was associated respectively with higher hemoglobin A1C in type 1 diabetes and with hepatocellular lipid content in type 2 diabetes. And so these findings point to diabetes type-specific mechanisms that are affecting insulin clearance, but that contributes to the same problem of peripheral hyperinsulinemia that's associated with both forms of diabetes, but indicates that there may be different paths towards intervention.
That's very interesting data, Mike. And as you said, there's still so much more we need to understand, right? And although there are many things that are common between different types of diabetes, but it looks like from a physiology perspective or pathophysiology perspective, there are some clear differences. So be interesting to see what happens as that field progresses. Now, the next study I'm going to talk about is also related to the idea of new onset diabetes, but in a different way. So Dr. Tina Xie and colleagues from Taiwan looked at the possible effect of COVID-19 vaccination on the risk of new onset diabetes in infected individuals. So using the TriNetX database covering 53 healthcare organizations across the United States, they looked at two cohorts. In the first cohort of over 1.5 million people, those who had SARS-CoV-2 had a 65% increased risk of developing new onset diabetes compared to those who had not been infected. Then they looked at a second cohort of over 83,000 vaccinated COVID-19 survivors and over 83,000 unvaccinated COVID-19 survivors that were propensity score matched. They observed that those that had been vaccinated had a 21% lower risk of developing new onset diabetes compared to those who had not been vaccinated. There was a dose-dependent effect as well, and the effect was more pronounced among the Black African American population than other ethnic groups. Even though we don't talk about much anymore COVID-19, I think everyone listening knows that COVID-19 has not gone away. So these data certainly continue to be very relevant now.
Indeed, Alice. And as new variants emerge and prior vaccine or infection immunity wanes, really so important to stay up to date with COVID-19 vaccination. And this is a terrific reminder of the benefit of being protected in advance of future exposure. Last pick for me is an article by Dr. Eric Renard from Montpellier University Hospital in France and colleagues, who assessed the safety and efficacy of automated insulin delivery using the T-Slim system with Control-IQ in individuals with type 1 diabetes who are at increased risk for hypoglycemia. They included 72 adults who'd had impaired awareness of hypoglycemia and also had to spend at least 5% time with hypoglycemia based on CGM time less than 70 milligrams per deciliter. And they were randomized 2-to-1 to either receive automated insulin delivery or standard sensor-augmented insulin pump therapy for a 12-week period. The automated insulin delivery resulted in an almost 4% less time with hypoglycemia than that seen with sensor-augmented pump therapy, while also decreasing time spent with hyperglycemia by 5%, so that the time spent in the normal glucose range that we're all targeting increased by almost 9%. Now, there were 2 severe hypoglycemic events observed on automated insulin delivery, so that's important to note. But I'd say these results show that reducing time spent with hypoglycemia is possible with automated insulin delivery without requiring this permissive hyperglycemia that's traditionally been recommended for individuals with impaired awareness of hypoglycemia. And while likely this does reduce, and we know from a lot of other studies, the incidence of severe hypoglycemic events, the ones observed in this smaller study do point out the fact that hypoglycemia risk is still not eliminated in all those affected by automated insulin delivery. And so there is still more work remaining to eliminate the barrier of hypoglycemia in diabetes.
Yeah, absolutely, Mike. And these data, I think, are very nice to see as a clinician, because I certainly talk a lot about automated insulin delivery and encourage individuals to use it. So it's nice to see these types of data. But your comments about hypoglycemia are very important to note. And along a similar vein here, Mike, the last pick that I have, Dr. Lois Donovan and other colleagues from multiple centers in Canada completed an open-label randomized trial of hybrid closed-loop insulin delivery in the postpartum period for women with type 1 diabetes. Now, you might ask, why study this? Well, the postpartum period poses unique challenges in general, but particularly when it comes to trying to maintain glycemic control, given the demands of caring for a newborn, breastfeeding, which can increase risk of hypoglycemia, changes in insulin sensitivity, sleep deprivation, et cetera, et cetera. So to address this, they enrolled 18 women with type 1 diabetes and randomized them to use the Medtronic MiniMed 670/770G system in either auto mode, which would be the hybrid closed loop, or manual mode, which would be the sensor augmented pump therapy, for the first 12 weeks after delivery. Then there was a continuation phase for weeks 12 to 24, whereby everyone was on hybrid closed loop. Women who received hybrid closed loop therapy in the immediate postpartum period had similar time in range but less time below range, defined as either less than 70 or 54 milligrams per deciliter. In the continuation phase, those who switched from sensor-augmented pump therapy to hybrid closed loop saw a drop in their time below range. These findings are helpful clinically to provide reassurance that use of hybrid closed loop in the postpartum period is not only safe, but I would say preferred, in my opinion, given the reduction in hypoglycemia during this particularly challenging period of time.
Yeah, and there's so much insight that these systems provide in terms of when insulin demands are changing. And as that's, you pointed out, Alice, happening frequently in the postpartum period, and being able to have that additional information to help individuals make adjustments, and those that are even being made automated in the background, is really just terrific to see this being documented. And again, another reason to help encourage and advise our patients to consider access to these technologies in advance of these periods where they could really benefit from them. So this brings us to the end of another episode, and in fact, to the first year of Diabetes Care on Air. I know that Alice and I have sure learned a lot this year, and we hope that our listeners have too. Please let us know how we're doing as Alice and I ready ourselves to take on 2024. And keep in mind that Diabetes Care is continuing to accept submissions of original art for consideration to be included on a future journal cover. And of course, a big thank you to all of you for tuning into this episode and spending time with us this year.
And on behalf of Mike, myself, as well as the whole team that brings you Diabetes Care on Air, the podcast, we are all wishing you happy and safe holiday season, and we look forward to seeing you in the new year.